Good evening, everybody. Thank you for joining this joint webinar with the EURENS and the ARMNet Consortium. And together with Professor Meteor, we will cover the outcome of vestibular fistulas, the ARMNet experience in the next 40-45 minutes. First, I'm going to talk about our recently performed study on the bowel function of patients with anorectal malformation type rectovestibular fistulas, and there are some items and issues that Professor Meteor will cover in more detail in the second part of our webinar. We have no conflict of interest to talk about. For those of you who are unfamiliar with the ARMNet Consortium, that was founded in 2010 by pediatric surgeons that are working in the field of anorectal malformation care, together with epidemiologists, geneticists, psychologists, and representatives of the patient organization from the Netherlands, Italy, and Germany. And they did so with the aim of exchanging data and knowledge to harmonize diagnostic classifications and interventions and follow up afterwards, improve clinical care, and perform research. And they did that by developing a database which currently contains over 2,600 patients. And based on these patients, a lot of studies have already been performed by our consortium with quite a few publications in the peer-reviewed journals. One of those studies I would like to present today, which is the bowel function and associated risk factors at preschool and early childhood age in children with anorectal malformation type rectovestibular fistula, an ARMNet Consortium study. It's quite a mouthful, especially the preschool and early childhood age. What we aimed for in this study was to look at the bowel function of patients that are around the age of 5 and the timing that they should be toilet trained. But because not all of those patients are seen in the outpatient clinic at that exact time, we performed a study on patients who are 4 to 7 years of age, and therefore said that this early childhood or preschool age. We were aiming at looking at the functional outcome of this type of patients, because in general they are supposed to be a good outcome of this low fistula. However, a lot of this evidence is based on single center experiences. The description is usually pooled with other lower types, such as the perineal fistula, and often in adults. So the counseling of parents with patients with this condition is difficult because we don't have the exact information to tell them what they could expect of their children when they go to school, which is a timing that is of big concern for most parents. So the aim was to evaluate the bowel function of this type of patients at the age of 4 to 7 years of age, as I already told you, and identify the risk factors for poor functional outcome. It's a multi-center cohort study within the ARMNet associated centers, and we register patient characteristics, associated anomalies within the factorial screening, look at the sacral ratio. We have surgical procedures inserted in the database, as well as post-reconstructive complications. And we describe constipation 1 year after reconstruction. And since a few years, we have adopted in a consensus between our centers that the bowel function score is a questionnaire that we use to evaluate the outcome of bowel function in general as standard of care. But this score is not within the database of the ARMNet Consortium itself, so therefore we developed a Castor database to insert those data. The groups were divided in based on this bowel function score, which I suppose is a lot of you are familiar with. It's a 7-item score from 0 to 20, focusing on some items that I will cover in a minute. And there's, based on those numbers, you can divide patients in 2 groups. The good group, which is a bowel function score of at least 17, which is supposed to be a normal outcome in patients of this age in a control group. And then those patients who are having a bowel function score of less than 17, which is quite a large group. So therefore, we subdivided this group into poor, with a score of 11 or less, and the group of in between 11 and 17, which is the fair group. We performed analysis to detect risk factors for poor function. We had about 200 patients eligible for this study based on their age, and we asked the individual searchers based on our database to insert the data of these patients, especially the 4 to 7 years questionnaire, into this CASTOR database. And the response rate was 75, so 49 patients were not inserted. And then 149 patients that were inserted, 10 of them had been lost to follow-up. Assessment of the bowel function score was performed in the age of 8 or older in 10, and 4 and lower in 4. Some of them had a developmental delay, which by itself has influence on the bowel function score. So they were excluded, and in the end we had 111 patients available for analysis. The bowel function score, which was originally described by Rinsala, is supposed to be filled in by the parents themselves, independently of the caregiver, of the surgeon or the nurse specialist. In our series, only 13.5% of the bowel function score were actually filled in by the parents themselves. Surgeons in clinic or nurse specialists in clinic in more than 40%, and based on files, almost 40% as well. What we saw was that the bowel function score the median bowel function score was 16, with quite a big range, and that there was some type of soiling, some extent of soiling in 65% of the patients. In more than 30% of the cases, there were fecal accidents in some way, and more than 70% of the patients, or 70%, was having constipation. And surprisingly, even about 25% of the patients were having some kind of bowel management program. Some other numbers: the factor association was about 1 in 4. Sacral anomalies, it is about the same. Tethered was seen in about 1 in 10 patients. And the below normal sacral ratio, which is the ratio below 0.74 in the AP view, is about 1 in 5 patients. Different types of reconstruction are being used for this type of anorectal malformation, mainly the PSARP, but ASARP in 30% of the cases, and mini-PSARP in 15%. In general, we saw post-reconstructive complications in about 22% of the cases, of which just less than half of them were considered major, based on the Clavien-Dindo classification. So the major were mainly patients that were seen in theater for some kind of intervention. Risk factors for poor functional outcome in the end were tethered cord and a below normal sacral ratio. If we zoom in on those patients that were having bowel management, so those 25% of patients, we saw that sacral anomalies, a below normal sacral ratio, a prior enterostomy, post-reconstructive complications, and constipation at 1 year follow-up were risk factors for developing such a condition, being either constipation or incontinence, that bowel management was deemed necessary. What we think needs some kind of discussion is that although we've seen that soiling has been seen frequently in about 65% of the cases, we see these kind of numbers are just a bit less in the general population as well, in pairs. So that raises the question whether or not this is actually a sign of sphincteric dysfunction. Is it an inability to feel the urge? Is there a suboptimal squeezing performance or inadequate treatment of constipation even? Or is it just a sign of poor post-defecation perioral hygiene in these patients of this age? As already mentioned, the bowel management is frequently needed, more than we see in literature. That might be because of the referral function of our involved centers, or a low threshold for initiating this bowel management because of good experiences within our centers. Below normal sacral ratio is a risk factor as well. although this predictive value has been challenged because there's a wide range of normal sacral ratios, and there's an influence on age on sacral ratio measurement. When you perform this study, when the patients are older, you may have a ossification of the os coccyx that was maybe not clear when you perform this study when the patient is just born. And the reproducibility of this study is supposed to be poor. There are reports that the reproducibility is poor. Considering whether or not to perform a colostomy prior to reconstruction is an issue that Professor Medio will cover in a minute, so I won't touch that. And looking at the complication that have no impact on general function. However, it was a risk factor for bowel management, regardless of being it minor or major. So we hypothesized that maybe any type of complication, being minor or major, could lead to increased fibrosis after this complication, or may limit the control on urge and end up leading to stool withholding behavior. And towards looking at the minor versus major complications, we want to stress that going to theater with a patient with a small dehiscence to put in some additional stitches, being under anesthesia makes it a major complication. But the same type of patient could be treated differently by another surgeon treating it conservatively, making it a minor complication. Though the minor versus major needs to be interpreted with caution. Of course, there are some limitations in our study. All of our data are recorded prospectively, but the parts that we wanted to look at on the bowel function score could potentially be inserted retrospectively, leading to misclassification or lost data. As we've already said, the bowel function score is supposed to be filled in by parents themselves independently. In our case, it was only done in a minority of cases. What we could tell you is that we have seen and looked at it, that it has limited influence, saying that the below normal percentage was not significantly different between the different types of obtaining the bowel function score. So the scores of the patients that had their bowel function score filled in by the surgeons during the outpatient clinic or from file did not differ significantly between the patients that were filled in by their parents. Unfortunately, we don't have any protocolized criteria for initiating bowel management, so different centers can deal with the problem differently. And there is, unfortunately, an arbitrary subdivision in bowel function score groups. For analysis, you need to divide those groups in between numbers or amounts. But in the first description of this bowel function score, the group of good had a score of 9 to 16, and the fair group between 7 to 11. So you can have a fair outcome with a score of 11, and again have a good score with a good outcome with a score of 9. So you need to have some divisions, and that can be pretty arbitrary and doesn't really reflect, or potentially doesn't really reflect, the actual outcome of this patient. In conclusion, the median BFS in rectovestibular fistula patients at preschool and early childhood age is nearly normal, but presumably not as good as we all thought it would be. And the majority suffers from some degree of soiling and constipation, and nearly 25% is on bowel management, which surprises us, and associated risk factors for poor outcome for below normal sacral ratio and tether cord, and for associated risk factors for the bowel management. It was sacral anomalies, below normal sacral ratio, a prior enterostomy, both reconstructive complications, and constipation afterwards. And then I would look at the future perspectives. I think we think that larger studies are needed to definitively establish the role of the below normal sacral ratio, tether cord, and other risk factors in the functional outcome of these patients. I think that the obtaining the BFS solely by the parents independently from surgeons will strengthen any future results, and that follow-up is needed to determine whether aggressive treatment of constipation, soiling, and fecal incontinence, which have been shown to are present in quite a lot of cases. At an early age in these patients may in fact lead to improved bowel function. And then I will give the audience to Professor Meeder. Thank you for your attention. See you in a bit.
Thank you, Harriet, and good afternoon all. So in the second part, we will address specific aspects of the treatment of a rectovestibular fistula, and namely the possibility to perform a single-stage approach to save the perineum, and then non-surgical aspect of early versus delay postoperative feeding.
I'm sorry, Paola, can you make your screen, the presentation, a little bit bigger so we can see the whole screen?
I think because
yes, there, perfect, thank you.
Okay. Okay, so regarding the first aspect, if to perform a single stage approach is not really an update, because this is a very old idea and as old as 40 years of age now, when this colleague from India reported on 67 females with low anorectal malformation. As Dr. Van der Steeg said, most of the reports pull together the perineal and vestibular fistula, but still is a fair number. And they reported that whenever you get the chance, which is the usual occurring event now to correct the girls in the first year of life, you may consider not to do a preliminary colostomy. And then almost 20 years later, these colleagues from Turkey again were reporting the possibility to correct the so-called low anorectal malformation without a colostomy. And also they introduced this important aspect to preserve the perineal body as much as possible. And they suggest to perform the anaplasty by what they call the crusade perineal skin incision. I'm underlining this because this concept will be taken back later on. They also had a fair number of patients with a very good outcome. And they didn't specify the length of the follow-up, but these are what they reported. So, and these are quite similar to what just Dr. Van der Steeg said. And then there are a few more reports about this aspect. These are again from India. 72 rectovestibular fistula, 1 surgical technique without with preoperative bowel preparation, and they were kept on fasting for 5 days with excellent outcomes. And again, they didn't specify the follow-up, but they report a continence rate as excellent. And if no megarectum was present before the operation, then constipation was unlikely. These subjects were both infant and toddlers. And another one, I'm just reporting some of what is available in the literature, those with a bigger number of cases, perineal and rectovestibular fistula. This is another part of India, 2 surgical techniques, constipation 26%, so exactly what Dr. Van der Steeg just told us, and with a very low number of complications and minor problems like wound infection or small adhesions that didn't require the local wound care. So they concluded that to repair this kind of rectovestibular fistula, this kind of malformation is feasible. Of course, need a careful surgical technique and accurate follow-up and toilet training needs to be provided. So nowadays, it is a technique that is definitely adopted from many centers, especially those with more experience. And there is not that much more to say because there are evidence in the literature. Regarding the second aspect, saving the perineum, this is more controversial. Again, this is not a new idea. Past 15 years ago, these colleagues from Nepal and then Adrian Bianchi reported the possibility to save the perineum. In this case, they were treating males and regarding the big series from Adrian Bianchi that was passed 30 years before the publication, he treated both males and females, and they reported excellent final result. As we can see from here, the aesthetic, the cosmetic is really good, but the way how especially these colleagues from Nepal reached this result is quite debatable. This is another paper from India. This is a very nice paper. They operated on 40 females, placing 2 catheters, one in the urethra and the other in the rectovestibular fistula that helped the dissection of the rectum. And they extended the incision from the coccyx to the anterior limit of the future place where to put the anus, preserving the anterior perineum to the fourchette. The rectum was identified and detached from the location in the vagina and closed. And these were their result: no wound infection, and as expected, some constipations and some prolapse. The cosmetics was really good with a good anal continence and a quicker operation. And we can appreciate from this picture, this is from their paper, the anterior perineum is preserved. And then on this subject, there was nothing else written until this year when 2 papers came out in 2 different journals, but with very different numbers. This is from Boston. She reported on only 6 patients that were both vestibular fistula, perineal fistula, and anorectal malformation without atresia. She performed a much smaller incision, so not extending up to the coccyx, and then isolating the rectum and again preserving the perineum. And as I said, this year, this other paper came out from the group in Washington, from Dr. Levitt, but with only 4 patients, and 3 of them were under colostomy. And they limited the incision to even a smaller one compared to the one from Boston, and basically performing that crucial skin incision that the Turkey people were proposing 15 years before. No postoperative dilation and excellent result. Then there was a lively debate in the literature because, of course, these authors claimed that the idea was from them, but then it was answered that because they prefer much smaller incision, this was a variant, an original variant of the technique from the Indian. Apart from this debate in the literature, the concept is that actually we can limit a lot the original posterior sagittal incision that Peña was proposing 4 years ago from the coccyx all the way until the fistula by limiting especially the anterior dissection. And then the last point, when to feed these patients, especially those who has no colostomy. A few years ago, the group from Nijmegen published this very nice systematic review. They pulled together more than 1,500 patients, and these were the surprisingly report. The wound complication, when it was reported, was really low. And even more surprisingly, the wound complications and constipation were statistically significantly more present in the group that was fed later than that was fed earlier. Of course, this as any systematic review, the quality of the study was necessarily low and there was a big heterogeneity, but it seems that early feeding is preferable for the postoperative feeding of these children. And again, this year, 2 more papers came out on this aspect, one opposite to the other. This is a very nice study. They took a big number of single type of anorectal malformations, operated with a single technique, and this is a randomized control study. Half of the group was allowed to be fed later on the 6th day postoperatively, and half of it was fed earlier from the 2nd day. And what they found was that those that were fed earlier had more superficial wound infection, more deep wound infection, and more cases of stenosis that required eventually surgery. So they concluded that delayed enteral feeding, providing some peripheral parenteral nutrition, is definitely of advantage because it keeps the perineal wound less contaminated. But because everything has its reverse, this paper says exactly the opposite. This is from USA, but with a different cohort of patients, much less patient, 2 surgical techniques, both males and females, and retrospective. What they have done, they allow the patient to be fed on the day of the operation or the next day, and a very short course of antibiotic, and even extremely short length of stay, is a medium 1 day. Most of them were dilated. 1 out of 5 had some superficial wound adhesions, and 11% of them required some dilatation under anesthesia, and they didn't mention any surgery. So based on their result, they recommend to early feed these patients because the admission in the hospital is stay and does not lead to the increased wound complications. So exactly 2 opposite positions. Also, a few years ago, Dr. Van der Steeg proposed this entrance study, which is from the ARMNet, one of the studies that the ARMNet consortium is able to put together, because it's a multicentric study and can rely on a high number of patients. 165 rectovestibular fistula were examined with the aim to understand the post-reconstructive complications and the outcome at 1 year of follow-up. All these variables were taken into considerations, specifically the presence or not of enterostomy. 20% of the patient had an enterostomy before the operation. Time of reconstruction, that was around 3 months of age. If they were bowel prep before the operation or not, length of antibiotic prophylaxis, and when they were fed postoperatively. Taking them one by one, no one has a real impact on the occurrence of the overall complications. But when some variables were taken together, and namely when the patient were bowel prep before surgery, they were kept on antibiotic prophylaxis for at least 48 hours. And they were not given anything per mouth for a period variable between 3 and 7 days compared to those that were allowed to be fed immediately. This eventually led to have the least major complication, as low as 6% of the cases. So the conclusion from the ARPANET study was that these 3 aspects should be respected in order to have the least number of complications. Then I will leave this for the next webinar because I think there is enough food for discussion now. I thank you. And we're ready to take some questions, if any.
Yeah, thank you very much. I have received 2 questions. I sent it through to you. I don't know if you could read them.
I read before one question that was during Harian's talk. There was about in case of Anastan or something like that, but I don't see it anymore.
I'll read it out. In case of VF associated with presacral mass, do we need to screen the family?
I'm sorry, what was the first part of your question?
In case of presacral mass, Harian, if you detect a presacral mass, will you screen the family?
No, I don't screen the family necessarily, but I think, well, in any patients, we send them to the clinical geneticist to see what the risk is for another child, or the risk in the long run for the child itself. But I'm not familiar with this fact necessarily, other than you have maybe a Curarino. But I think if you end up seeing that in the general or in the clinical geneticists, that you must screen the family after that, but not necessarily from upfront.
And I'm asking you instead, do you, if you have a patient with the presacral mass, do you perform the genetic research? So in case there is the MNX-X1 gene, then maybe the family needs to be screened, right?
I would do that in that. I would do that in that sequence. So first, send them to the clinical geneticist, and then when something is proven, then you can screen the family. But in our case, we usually send we give the patients and the parents the possibility to be screened by the clinical geneticist anyway, regardless of any findings. The RMS is enough.
Then I see a second question for both of us, I guess. Are these, these patients repaired in the early neonatal period or dilated and repaired at 2 to 3 months? Do you want to answer?
Our patients have been treated mostly in the first few months of their lives, but not necessarily. But in general, it's about 3 to 4 months of age.
Yeah, this is our experience also. If we get the chance to have in the house the patient, then we try to operate within 2 days, because the meconium is sterile before she has been fed. But rarely we got the patient in the house. We receive it like a month later. And from the literature that I reported, there was a combination of infants and toddlers. So even quite later on in their life. And so another question is similar to the first one. And then, do you think there is any significant perineal body in rectovestibular fistula? Yes. Yeah. I would say. In the rectoperineal fistula, there might not be enough perineal body because you need to detach it from the perineal body. But in the rectovestibular fistula, actually, yeah. Yeah.
Next question. Do you think the increased need for bowel management among those who receive an enterostomy is due to the colostomy, the surgeon experience, timing, or operation? We're not sure. As we stated in our paper, is that we're not sure whether or not the enterostomy itself has any influence on the outcome, or that the enterostomy itself has been given because of certain problems, but we don't look into that in our database. What we did ask, because we asked all the surgeons concerning their patients, is whether or not these enterostomies were performed prior to the reconstruction, so as a general practice, or after the surgery as a way of preventing complications or even treating complications. And there were only 2 cases of patients that were receiving their enterostomy after surgery, so as a means of treating any complications. So we don't know, at least not from the database.
There is a question for you, to Herian. So this is for you. I read it.
Yeah, okay.
Did you check which is the possible associated malformation? Now, did you check which of the possible associated malformation could have the more relevant impact on the outcome? For example, spinal malformation or others?
Well, we've looked at spinal malformations as well, but we found that the tablet cord itself in a low sacral ratio or below normal sacral ratio, because we did not define what is low. So we think the cutoff point is 0.04 in the AP view. So everything below 0.74 is below normal, but even 7.0 is not a bad sacral ratio. So we're not sure, but we did not go into depth in that case. We said it's below normal. So the spinal malformation in general did not give any clues about the tablet cord itself, but it depends on what kind of study you read, because there's spinal malformations that do have influence. In this case, we did not see concerning the bowel function an outcome or an influence. Perineal groove, do we need to operate or no?
This is for me. No, we don't need. We don't need, definitely, because it will eventually epithelialized. And it takes more than a year, sometimes 2 years, but it gets the epithelium, then the skin runs over. Provide the fact that the anus is well centered and has a good diameter. So it's not a perineal fistula with perineal groove, which is unusual. Usually you don't need to do anything, absolutely nothing. The next for you, typically, do you dilate the fistula or create a colostomy? No.
It depends on the size of the fistula. If it's of a reasonable size, then you don't need to dilate. I think
what is a reasonable size? What's the?
We've published on that before, and we think, but it's just a number. We aim at least at 5 when they're born, but in the end, it doesn't really go about numbers. It's about if a child is able to have stool through this fistula, and whether or not it's 4 or 17 doesn't really matter. But you need some numbers to aim at. So we aim at 5. For example, today, because 5 is pretty small, we ended up having a patient who is already 7 months of age in our outpatient clinic. She was referred to us because the anus looked awkward, and she has a perineal fistula with a size of 6, and she's eating normal food, solid food. So it's not all about numbers. It's whether or not you can have stool through this anal opening. So What we do find interesting is we still dilate patients after reconstruction. So if you teach parents and the patient to have dilatations or calibrations prior to surgery, it's not a surprise for parents what to do after surgery. So they get accustomed to this practice, they and their child. So we usually don't give them a colostomy.
Yeah, and regarding my experience, first of all, I try to operate before weaning. So while they are still on 100% milk, because the feces goes easily even through a smaller anus, 5, 6, 4. So try to, before the 4 months of age, to repair the child. We start just with the PSARP, and in the last 15 years, I had to perform only one colostomy at the time of PSARP because the operation get more complicated. So it was like a rescue colostomy. And basically is one-shot colostomy, and we fed them only clear fluid starting in 2 days, and we give 2 days of antibiotics, and keeping the urinary catheter just with the idea to try to keep as dry as possible and not to have pee that flows all the time on top. And then another comment from Bruno Martinez-Leo, very interesting findings. Thanks for sharing them. I'd like to stress out that the prognosis relies more on the patient's prognostic aspects rather than the technique used. Yeah, definitely. Provide you are an expert surgeon, because that's also important. As you said, Herjan, there are some factors.
Yeah. I think if you see that complications have influence, and of course there's more. And for example, the paper you touched on the postoperative feeding that recommended doing it late. That's exactly what we were looking at in our paper. But if you just changed your postoperative feeding regime, you must be sure that all the other elements, such as the preoperative mechanical bowel preparation and your antibiotic prophylaxis, is all the same. And this was an RCT, so more centers are involved. And that's what we saw in our study, that within European centers of expertise, there's a lot of different ways of treating these patients. And for example, the antibiotic prophylaxis, I think we had 25 different ways of doing it. The length of prophylaxis, the type of antibiotics given, the same accounts for mechanical bowel preparation, enemas, liquids, fluids, 1 day, 2 day, 3 days prior to adding antibiotics. There's multiple ways of doing it. So it's really hard to actually tell what type of intervention actually has influence on what. And that's why we, in the end, said that, okay, if you have mechanical bowel preparation, whatever that may mean, antibiotic prophylaxis for at least 48 hours and nil by mouth for a few days has the least amount of major complications. But again, major complications, if I take my patient with a small dehiscence to a theater, I have a major complication. And if Paula says, oh, I can take care of it by just rinsing it and doing it conservatively, it's a minor complication. So we all need to take these outcomes really cautious. And we don't, based on our study, I don't think we should say that what we told now, that the mechanical bowel preparation, antibiotic prophylaxis for 48 hours at least, and nil by mouth is the best way. It's a way, but it makes it really hard because everybody is just treating a small amount of patients. But at least we have a clue on what's preferred.
And then there is a last question. In delayed case with megarectum demonstrated by rectogram, do we need to do tapering? That's tough.
Okay.
It depends how late the girls arrive. If she has few years of age, 3, 4, 5 years of age, yeah, usually the rectum are really big, and it could be wise to perform a loop colostomy and have it decrease the size, because to taper means you don't go only through the perineum, but you taper all the way up into the abdomen, because megarectum is not just the last 3 centimeters, it's much bigger in the abdomen. So I had very few cases of that, and we open up a colostomy, a loop colostomy, give time to decrease the size, and for sure in the long term she will need bowel management all the time, because whatever is enlarged and then fibrotic and has lost some elasticity. But I would first be conservative instead of taking out or do the tapering. What would you do, Harian?
I agree. It depends, I think it depends as well on what is the size of the rectum when the patient was born, whether or not to see it has been increasing due to, for example, surgery and any stenosis, or it's just an outcome of a already dilated rectum, and that gives you a clue on whether or not a colostomy is reasonable. But I think I would start anyway to see whether or not you can save the rectum or decrease the risk of doing a tapering when doing the reconstruction, because it's an anastomosis on anastomosis with a higher risk of leakage.
Yeah.
Great. Thank you very much for answering all these questions. And of course, thank you for your nice presentations. For the people at home, the webinar has been recorded and will be available on both our GoToWebinar platform and the YouTube channel. And I will be sending the links tomorrow. Something important is that this webinar is EACCME accredited, and all of you who have attended it live can receive accreditation if you fill in the survey that you will receive immediately after the session. And of course, we would be grateful if you could spend a few minutes filling it in, because it also helps us improve for the sessions. But for now, I would really like to thank Harian and Paola for the nice presentation, and all of you who was attending, and wishing you a very good night. Thank you.
You're welcome.
Thank you. Goodbye. Bye-bye.
Bye.
Bye. Bye.
Bye. Bye-bye.
Bye-bye, everybody.